teachers and the students for this another case discussion for the today. I welcome all of you. I would like to request Dr. Ruchira Madam to say a few words before we start our lecture.
Thank you, Dr. Arif. Thank you. Again, though it's a routine, every week, Baldev Prajapati sir, he just make all of us more wiser with his teachings. So everybody look forward for it, and me too. But just a formality. On the behalf of Indian Academy of Pediatrics, I welcome you all for this another session in succession, that is learning from masters. And for that, again, my gratitude to our teacher, a teacher of teacher, Dr. Baldev Prajapati sir, who had consented to be the expert for this session. And he is actually giving his valuable time for this every week, every Tuesday. Means a lot, sir. We understand you are such a busy person. Despite that, you are here. And also, um, then today's what should I say, mentor, Dr. Murki sir, a known figure, a known face across the country. Everybody knows him very well, and we know his clinical acumen, clinical expertise in field of neonatology. He's a well-known neonatologist. So, sir, on the behalf of IAP, I welcome you for that. And the today's trainee, as well as all the viewers, postgraduates, the colleagues, and the members of Indian Academy of Pediatrics. It is truly indeed, and what should I say? It is a satisfying thing that every week something which is more meaningful is being conducted, and for this, the credit goes to the leadership led by Dr. President Dr. Neela Mohan Madam, President-elect Dr. Singh Ravelu sir, past President Dr. Vasant Kalatkar sir, and all our presidents, specifically I can see Dr. Sandeep Trivedi sir, and our treasurer Dr. Bhandari. So once again, I wish you best of learning. Thank you. Over to you, Dr. Arif.
Thank you, madam, for your encouraging words. I would like to request Dr. Neelam Moham, madam, our president, to say a few words before we proceed.
Three words. Best wishes to you, beloved Arif. Please proceed, dear Baldev ji. Please proceed with the good work. I'm also listening. आज क्या चीज है मैं भी थोड़ा सीखूं आपसे. Sorry, Singravelu is there, so he will not like Hindi. I'm saying Singravelu sir, you also learn from
Thank you, ma'am. Thank you. Same way. Best of luck. Only thing, congratulations to Baldev sir. Already he is doing. And more, my good friend Srinivas Mukhi is there.
Yeah.
Sir, it is a very proud moment that a great teacher has joined. Surely, sir, under your vision, our PGs and everybody will be learning with Baldev sir vision. Thank you, sir. Without wasting much time, over to science. Thank you.
Thank you, Neela madam and the Singer Velu sir. I would like to also acknowledge the presence of our Vice President, Dr. Sandeep Trivedi, and other senior teachers who have joined for the today's session. So today's session, it's from the Hyderabad. So I welcome the team from the Hyderabad. The presentation is going to be done by Dr. M. Nikhila Reddy. She is a second year DNB resident from Ankura Hospital for Women and Children, Hyderabad. And her mentor is our own Dr. Srinivasan Murki sir. He's also from DM Neurology and MD Pediatrics from the Ankura Hospital, Hyderabad. I welcome both of you. And I would like to acknowledge this sir, Murki sir, because sir has approached us when you are giving us the slots through the Baldev Prajapati sir. And the sir's the academics and enthusiasm is too much, and we are fortunate that the sir has approached us and give us the, and also provided the this today's case. So very thankful to the Murki sir. And I would like to introduce our convener, our teacher who teaches us on every Tuesday. And not only the students, we as in faculty and many, I can see many pediatricians who listens to sir lectures throughout the 2 hours. So it's such a blessing. So I would like to introduce our convener, Dr. Baldev Prajapati,
Please,
sir.
please, Dr. Arif, will not take much time. It's all right, I think.
Okay, sir. So, sir, it's over to you.
Yes. Good evening, friends. Welcome to this our IAP Tuesday PG Clinic. Thank you very much, the office bearers, our president, Dr. Neelam Mohan Madam, and Dr. Ruchira Gupta for their kind words and best wishes. And yes, as Dr. Arif said, we acknowledge the presence of you and the senior teachers on the screen. Let me express a few words regarding Dr. Srinivas Murthy. All of us know that he himself is one of the best teachers of this country. Best, I will say, very good clinician in neonatology. To be very frank, I also learned a lot from him regarding the neonatology at several, I will say, academic beats. And when he said to give the opportunity, I will say that, Dr. Murthy, you are kind enough that you have given us the opportunity to discuss with your student. Every time it's not so that we are giving the opportunity. Sometimes we get the opportunity. And I think here, let me acknowledge in that way. Certainly, all this, that is, I will say, the way that how there will be the participation across the country when the teachers are ready to motivate the students. And all of us know that learning is mutually. Not only we are teaching the students, while I will say interacting with them, we also learn a lot. And certainly, I would say the Hyderabad team is very dynamic. Students also, several times I have interacted. And let us see that how best we can utilize this our evening for learning the pediatrics. I request all the students that please keep your video on. And whenever you feel, please participate in the discussion. Put your comments, your questions, some of your, even I will say, controversies which you may not agree with your presenter, even sometimes teachers. That Sir Nielsen mein to aisa likha hai. I think one should speak like this. That's very important. And that's the thing that how we can make it a live session and we can make it more of the interactive and I will say best learning. With this remark, I request today's presenter, Dr. Nikhila, to share her PPT and start the history part. Dr. Nikhila, please.
Good evening, sir.
I think before that, Nikhila, can you help me to identify some of your friends on the screen so that during interaction I can name them and invite
yes,
them? Yes, please.
Yes, sir. From my institute,
Yeah.
Dr. Vidyashree, Dr. Mayuri,
Yeah,
Dr. Ravinder, Dr. Prashant, Dr. Jyoti.
right. So I
And
think
my
you have come with
mentor.
your team. That's good.
Yes.
Very good. And I request everybody that please, Nikhila should find the difficulty in the presentation. You should be ready for that. Thank you very much, Dr. Nikhila. You can start the history, please.
Yes, sir. Sir, I
Fine.
hope my screen is visible.
Yes, very well.
Yes, sir. Good evening, everyone. Thank you for this opportunity. Let me proceed with my case. With an 8-year-old male child, developmentally normal, was brought with complaints of abnormal movements of upper body since 20 days, slurring of speech since 20 days, cold and cough since 15 days, and fever since 2 days. This child was apparently asymptomatic till 20 days back when he started to develop abnormal movements of upper body involving hands and trunk, which were involuntary, asymmetric, non-repetitive, purposeless movements, with left upper limb more involved than the right upper limb. They were reduced in sleep and predominant when in awake state, also associated with lip smacking movements and licking movements of the lips. This child had difficulty in self-feed but was able to eat when fed by parents. Swaying of gait was noted. He had difficulty in walking in a straight line with frequent deviation to either side. Parents noticed dancing irregular gait with sudden jerky movements of the limbs. And also, he had slurring of speech since 20 days. Previously, he was speaking normally. Then, parents noticed that his speech became unclear, poorly articulated, and difficult to understand. He appeared to know what he wanted to say, but unable to pronounce the words properly. He also had cold and cough since 15 days, and cough was non-productive. We had history of fever since 2 days, which was high grade, intermittent fever, relieved with medication, and interfebrile period. He was active. Also, his mother gives history of multiple episodes of cold and cough with mild throat pain on and off, which were treated symptomatically with cough suppressants and nasal decongestants.
Yes, Dr. Nikhila, can you stop sharing for a while?
Yes, sir. Yes, sir.
Let me start to interact with some other students. I think what Nikhila described some symptoms in 8-year-old boy. I think Dr. Hardy probably is not from the same institution, may not be aware regarding the case as I am. Dr. Hardy, what is your impression that what system is likely involved in this patient? Dr. Hardy, are you there? Yes, Dr. Teja. I know that he participates regularly in the discussion. Dr. Teja. Yes, Dr. Kirti. I think
Sir,
Dr.
most likely
Yes,
CNS.
yes, Dr. Teja.
Most likely CNS involvement
Very good. Why CNS?
because of the abnormal movements of the body with swaying and
Right.
slurring of the speech.
Yes. And then can you even try to make out the anatomy just from the symptom? Suppose if you say that it is a likely problem of nervous system, then which part of the nervous system is likely involved from this description? What she described. What Dr. Nikhila described, I hope that you have attended it regarding this movement
Basal
problem,
ganglion.
then the gait, then speech. Yes. Why the basal? Can you make your video on? I think we would like to interact so that if you don't mind, Dr. Teja. Why did you say that basal ganglia? That means how you are, I will say, able to link the problem with this basal ganglia.
Because of extrapyramidal motor system.
There can be the various manifestations of
Maybe.
extrapyramidal, but what is the very specific?
Abnormal jerky movements.
Okay. Let me start, I will say in this way that what do you call it, this type of the movements? Dr. Teja, as a whole, what do you call it? As a problem. I'm not asking regarding the condition or diagnosis. As a problem, the way in which she described these movements of upper limb, lower limb, everything, what do you call it?
Chorea, sir.
Okay. You know, as a whole, we call it as a movement disorder.
Movement.
Right. Why I'm coming to this point, sometimes even you may get the full theory question regarding the movement disorder. And I want to draw the attention of all exam going students that please prepare the whole, I will say, question, answer properly, that how you can describe the movement disorder. First, let us even take this some time to understand this movement disorder. What do you mean by the movement disorder? Anybody? What is your understanding of the movement disorder? Yes, Dr. Abhishek? Dr. Monica? Try to respond. We don't know exactly, probably book description may be different, but what we mean by it, our understanding regarding the movement disorder. Somebody may ask that, define the movement disorder. Dr. Jyoti,
which is not normal.
Yes, Dr. Monica, very good. Please.
So, what is not normal? It is not like routine work. If something happens abnormal type, which is not normal.
Very good. You know, try to find out the different adjectives. One adjective was Dr. Monica said that it is an abnormal movement. Agree. Second thing, what type of the abnormality or what type of the movement it is? That means it is by the desire of the person or it is beyond the control of the person. Monica, you can take it further.
Yes, sir. So without the desire of the patient.
Then what do you call it?
Patient is not
What do you call it? It's an involuntary movement. Doctor,
involuntary. Yes, sir. Involuntary.
Blissby, I think last time also you please rename yourself. It will be the good that we can identify you properly. Your comment is very good. So it's a abnormal. It's an involuntary movement. Very good. Try to find out one more adjective. One more adjective for this type of the movements. Usually they are excessive involuntary movements. So abnormal, excessive, involuntary movements. And then what problems develop due to this involuntary movement? What the problems you observe in the person? Whatever may be the abnormal. Yes.
Hampering in the routine work, sir. There can be not, the patient will not be able to do the normal routine work like brushing the teeth, combing the hair,
right.
Or writing abnormality, sir. So the patient is school going now.
So all these problems, what do you call it? Suppose some words you have to describe. What do you call it? Your description is right. That he's not able to walk properly. He's not able to. He's not able even to sit properly. He's not able to even eat properly. Here, he's not able to even speak properly. Then what do you call it? That means, you know, this is the movement disorder is the condition which is abnormal, involuntary movements, usually excessive in nature. And it results in problems of posture, tone,
speech,
balance, speech, and even motor control as a whole. If you see motor control, I think it includes everything. So please remember that what adjectives we can remember. Motor disorders is a condition which is recognized by abnormal, excessive, involuntary movements and which results in problems of tone, posture, even the balance or gait, and motor control as a whole. So, you know, this is very simple definition, and I think there is no need to mug up. Just if you understand that probably here and there some change of words will be there, but you'll be able to explain. Now, having this type of the movement disorder, if we come to the description, what Dr. Nikhila has given to us, what type of the, first I think before that we should know that any movement disorder, what questions you will ask to the parents or the child to gather the information so that it will help you. You know, our aim should be there that what is our aim of asking the questions or gathering the information. We want to define the exact pattern of the involuntary movement, type of the involuntary movement. So for that, we should ask the question. Second, we try to know that what is the possible reason or cause for this type of the movement disorder. Keeping in mind this type of the problems or conditions, we will gather the information. So Dr. Monica, can you suppose any movement disorder, what type of the questions you will ask? Please, come on. Any movement disorder.
Sir, how it began, how it started.
Yeah, very good. So always remember our medical terminology. That means first is the duration.
Duration.
And duration will give the idea. Is it acute, subacute, or chronic?
Chronic, yes, sir.
Right. Try to think in this way. That whether it is acute, subacute, or chronic. Therefore, duration. Second, always in our history, what we say, onset.
Onset.
Whether was it sudden or gradual.
Yeah.
The reason is, you know, that will give us some idea that what can happen suddenly, what can happen, I will say slowly or progress, gradual onset. So which will be acute, which will be of chronic. That will be give some idea for regarding thinking of its pattern or regarding its etiology. So that's a very good point, the duration. Then the onset. Further, What will you
The
try to understand?
frequency,
Very good. What the frequency will give the idea, Monica? I think you can discuss this point as a whole with you. What frequency will ask? Or we will see, or we can also observe. Movement disorder can be that, we should have the sound knowledge. If
yes,
we have
sir.
the knowledge, we can ask the different questions and we can gather the information. Knowledge that means, suppose, usually movement disorder can be hypokinetic or hyperkinetic.
Yes, sir.
That means maybe slow or very rapid. And that you can see even suppose slow. Monica, can you give an example for the slow movement or hypokinetic movement disorder? One example.
So slow.
That's why I asked a difficult question. I know that rapid you might have answered. Anybody? Yes. Slow is probably not so common in not so common in children.
Sir, Corifa movements.
No, it is rapid. Very good. Dr. Abhishek put Parkinsonism. Yes, it is a slow example of the slow movement or hypokinetic. Hyperkinetic, I think so many, chorea, athetosis, polyathetosis, even the myoclonic, even the tremors.
Tremors. Yes.
Yeah, all these are the examples of hyperkinetic. So that's another thing you will try to know whether it is hypokinetic or hyperkinetic. Then what other? Whether it is intention or without intention. Sometimes if you go for action, it will be precipitated. And sometimes without action also. So that also will give you some idea. Then associated symptoms. Suppose fever is there. Or even history of something is there. Right. Or history of drugs even. That is very important. Anybody can give the point of drugs, that which drugs can cause these movement problems? I'm sure that not uncommon in the practice.
Antipsychotics.
Very good. Dr. Teja, anything?
Metoclopramide.
I will say take the common drugs. Common drug. Which one as a pediatrician we are using?
Metoclopramide.
Metoclopramide.
Very good. Metoclopramide. Fortunately, we have decreased. But somebody will ask, is it possibly the domperidone which we are using very frequently, commonly? Can it occur with the domperidone also?
Don't know, sir.
Yes. Domperidone is also, compared to metoclopramide, it is less common, but yes, it is seen. Even somebody suppose asking to the practitioner like me, have you seen the patient? Yes, we have come across. I think later on we'll take some examples. Then you should keep some other drugs also, which will create the problem.
Salbutamol called fine intention tremor.
Very good, very good. Yes, salbutamol can cause it. Absolutely. Good point. I will appreciate. So, in short, better to go in the details of drugs. Sometimes drug itself may be responsible for dyskinesia. And probably it may not require further workup, evaluation, anything. Just you can stop the drug, treat symptomatically, and probably within few days, patient will be all right. So that's very important, that how we can, even history of some trauma or history of some disease, even the disease can present with these movement disorders. Let me take that point also. Dr. Mayuri, please come on. Do you know any disease disorder which may present with movement disorder? And then you realize that, oh, this movement problem was due to this particular disease. Can you
see the vitamin B12 deficiency, sir?
Sorry?
ITS, infantile tremor syndrome. Infantile tremor syndrome.
Very good. Infantile tremor syndrome can cause it. Any other? Any liver problem? I will give some idea.
Wilson's disease.
Wilson disease, yes, Dr. Teja, very nice. Wilson disease, particularly, neurological manifestation in the older child, they may present. Any other disease? Still, movement disorder?
Hyperthyroidism. Fine tremor.
Very good. Hyperthyroidism can present. So, these are the things. Even sometimes cerebral palsy itself, very common. Or even sometimes.
In children, sir? Parkinson. Parkinson's in children?
Yes, Parkinson in children, we don't get much, I will say common, but yes, that is known condition. Then sometimes, suppose if it is the myoclonic type.
Yes.
Myoclonic type in the older child, 10, 12 years old child. Just recently, I think we had some case in the Tuesday clinic we discussed. Even
So
SSP.
substance abuse, sir. Some substance abuse.
SSP can play there. Just substance abuse can play there. What was
Withdrawal.
my idea? What was my idea to asking all these things? That you should have the idea to gather the information, and for that various questions you can ask and collect the information. One more question regarding, suppose already child has no particular, I will say, movement disorder when the child is brought to you. Just parents are providing the information and you are not sure what even the parents describe, we may not be able to understand. Then what is my idea? That in this type of situation, how will you try to understand this movement problem? Anybody? What are the various modalities, what I mean to say, in the history, which probably description may not be clear, then how will you try to clarify it to the parents? Anybody? Dr. Jyoti? I think nowadays in this modern time, you should have the answer.
Video.
Yeah,
Video.
exactly,
Videography.
Monica. Yes. You can ask the parents, suppose by chance if it is not continuous, you can say whenever it happens, capture the video or any other modality. You know, you can even show the various things that the movement, or you can ask the parents that can you show me that what of the movements child is doing from the, I will say, mimicry by the parents will also make some point clear. Or we can ask, or even nowadays you have the video in your computer. You can show that various videos, that any of these are you able to identify? Why I'm actually coming to the most practical questions, that these points will help you a lot. Many times it is not so clear from the description. Anyway, so I think coming to this point of the movement disorders, we should have all these points when we are trying to discuss. Anyway, now coming to our case, back to our case. Let me even again ask the yes.
Sir, just I wanted to add a few
Murthy
points.
Sir, please. We wish your comments, please.
So I think, the Clays has told us that I think the residents are very good at telling that it's a CNS problem. So, and they have tried to localize it to the basal ganglia. But I think important thing is whenever you have a CNS problem, we can localize from both positive and negative history. Here, sensorium abnormalities, seizures were not there, sensorium abnormalities are not there. That will be, and IQ abnormalities. This will rule out mostly the cortical problem.
Absolutely.
And motor problem usually will not have other associated features like what you have seen, but hypotonia or hypertonia features of are something related to the myelin. Then coming to the triad of features which you have in this child is, one is abnormal movement, second is a speech, third is a gait. This sort of combination either you will see in cerebellum, brainstem, or in the basal ganglia. So I think further down we need to find out what exactly, whether it is basal ganglia or whether it is cerebellum. So the type of movements, the type of speech, or the type of abnormal movements, you will help us to say, because both will have cerebellar and basal ganglia will have tone abnormalities, gait abnormalities, speech abnormalities, and abnormal movements also. But the type of movements, the type of speech will be able to help us differentiate these type of disorders. Now, from the type description, it looks, and we all know that basal ganglia movements are mostly isthmus. So these are the movements which we all know, and differentiation
Dr. Murthy, there is some problem of net issue at your end.
Sorry, sir.
No problem.
From the history, we know that it is the basal ganglia, and from the description, it appears that disorder, because we're not talking about tremors or titubation, or even the speech disorder, which she tried to tell us. They said corticosis, hemiplegia. These are three types of disorder which can be localized to basically. Now, these three also we can try to differentiate one from the other by where exactly the movements are. what type of movements, whether they're affecting proximal or distal, whether they are hypo or hyperkinetic, whether the voluntary or involuntary, whether you can suppress or whether you can
Yeah.
stimulate. Some of them can be suppressed, some of them can be stimulated disorders. And sleep, how the sleep is affecting the disorders, whether the child is able to sleep well or not. And the other associative features will tell us the etiology. Now, from the type of onset and duration, will give a very important clue for the etiology. But associated features, fever, loss of weight, loss of appetite, cough, or drug history. So these will tell us about the etiology. So I think whatever you said, I am totally with it, sir. But I thought this will be another method to see how we localize first,
Absolutely.
and then try to pin out the etiology.
Yes.
Over to you, sir.
Yeah,
Over.
yeah. I think I'm sure that the listener will have the idea whether Dr. Murki is a neonatologist or the neurologist. The way he is describing regarding his concepts, but it is absolutely good. And the reason I understand that Dr. Murki is now neonatologist, but it means he has learned a lot in even the MBBS and pediatrics also. And that is, I will say, the good quality of super specialty. That's another point which you'll have to learn from him. That we should be the basic.
All pediatricians.
Yeah.
All pediatricians should be able to localize a neurological problem.
Yes.
And etiology is common to all, sir. Common to all.
Absolutely. Very good point. Anyway, now let us go to further. Dr. Nikhila, can you share your PPT and take it further?
Sir. Yes, sir. Sir, my screen is visible, sir.
Yes. Can you go to now? From this we have to start.
Yes, sir. There is no history of loss of consciousness, uprolling of eyes, tongue bite, altered sensorium, or irritability. There is no.
I think Dr. Nikhila,
Yes,
I will
sir.
request you. Can you give the explanation yourself for each point? That why did you ask this point? What was your idea?
Yes, sir. There's no history of loss of consciousness, uprolling of eyes, tongue bite, altered sensorium, irritability, like cortical involvement. I wanted to rule out, sir.
Yeah. I think another way simply you can say to differentiate that it was not the seizures.
Yes, sir.
Right. From this description, you wanted to differentiate.
Yes, sir.
We'll have to differentiate the abnormal movement from the seizures also. Because already you said that there was the lips, the smacking was there, or even the movement of orofacial, and that can happen in a case of the seizures also.
Yes,
So
sir.
that's why I think that, but the altered sensorium or consciousness is not impaired. That favors the absence of seizures in spite of these movements. Very good.
Yes.
So
Yes.
from this description, you say that yes, it is not the seizures, but the movement disorder. Good.
There is no history of focal weakness, facial deviation, or sensory loss, sir. Which I would rule out any like structural lesions or any stroke.
Right.
There is no history of headache, vomiting, visual disturbances, like it is against any raised intracranial pressure or encephalitis, meningitis.
Right. Very good.
No history of recent head trauma to rule out any bleeding.
Yes.
No history of drug intake like antipsychotic, anticonvulsants, antiemetics, which could lead to drug-induced movements.
Very good.
No history of jaundice, recurrent blood transfusions, liver disease to rule out Wilson's, sir.
Recurrent blood transfusion for? What is your idea? Jaundice, we
like
understand.
Chronic liver disease.
Okay. That will be not, Wilson, this blood transfusion is not going to be common.
Yes. Okay.
So, yeah. So I think another thing, that's why I'm saying always avoid something which may create the problem for you in the exam, because we may not be able to explain properly. No history of jaundice, probably yes, or any liver disease, just to explain that at least there is no possibility of Wilson disease. Good.
Yes, sir. There is no history of developmental delay, cognitive decline, or similar illness in the family to rule out any inherited movement disorders or any inherited neurodegenerative disorders.
Right.
There is no history of like recurrent fever, weight loss, or tuberculosis contacts, sir, to rule out TB.
Mhm.
And no history of palpitations, chest pain, breathlessness, syncope to rule out any cardiac involvement to look for
Right.
carditis.
Okay, but is it possible, as you said, fever, weight loss, tuberculosis, whether tuberculosis can present in this way?
Tubercular meningitis.
In the absence of even the meningitis?
Uh,
Purposefully I asked the question.
any chronic inflammatory etiologies?
Yes, even in our country, on the contrary, these are the presentations of tuberculosis is known.
Yes,
They
sir.
do present, may not be so common, but yes, occasionally we do come across. It reminds me, Dr. Nikhila, that
Yes.
in our own unit long back, one very young child, about 3 years, was hospitalized with this type of the choric moment. One of our residents put the diagnosis of rheumatic chorea.
Oh.
You know, the only point for me that rheumatic chorea should not present at the age of 3 years.
Yes, sir.
And therefore, we went for the CSF and the MRI brain turned out to be the CNS tuberculosis meningitis, with involvement of the basal ganglia. So the point is very known. That type of the presentation for CNS tuberculosis may not be common, but yes, it is known and it can happen. So it's a good point. On the contrary, the exam, suppose if you want to present this type of the point in the exam, after mentioning this point, wait for some time,
Okay, sir.
even the pause, and
Yes, sir.
give the time to the examiner. That do you want to ask me the question or should I go further? Right. I think
Yes, sir.
the good candidate can, I will say, try to find out such points of the discussion for your good performance. Very good. And somebody rightly put it on the chat box. I think Dr. Abhishek, that even the subacute or chronic, this type of presentation, even the odd presentation, tuberculosis should be ruled out. Very good point. Okay, now take it further.
Yes, sir. Past illness, this child reported to have multiple episodes of upper respiratory tract infection. There were no history of like similar complaints in the past, and there is no other significant past history. Antenatal was uneventful. He was born to second degree consanguineous couples, spontaneous conception, antenatal uneventful.
I think, Nikhila, for the good presentation, the exam point of view,
Yes,
you
sir.
know, undergraduate students about presenting in this way, I will listen very without interrupting the student because they don't know. But from the postgraduate, your presentation should be lucid, very appropriate, and I will say you will focus more on the concern problem. Suppose that some child has presented with a serious problem in the form of suppose cerebral palsy. I will go all the details of antenatal, natal, and postnatal, NICU admission and everything.
Yes,
But I
sir.
think in the 8 years old child, when it was nothing with it, was no development, any problem in the past, probably this part I can make it lucid presentation that I went in the details of
Yes.
antenatal, natal, and postnatal history, but no significant point was found.
Okay,
That
sir.
in one line answer you can present, and then it becomes the, I will say, palatable. You know, the listener should like to listen that yes, it's a good presentation, like that. The only
Okay,
thing that the two abortions should be kept in mind, but that clarification you have given from the cervical incompetence, then probably
Yes.
may not be much related to our issue, right?
Yes, sir. Yes, sir.
Okay, fine.
So antenatal, natal, and postnatal history was uneventful. Thus,
Right.
this child required NICU stay for respiratory distress for 7 days, but otherwise it was normal.
Right.
It was a developmentally normal child. He's currently studying in 4th standard, attending school regularly with good scholastic performance. He's interacting well with friends. Currently hasn't been to school since 20 days due to illness.
Okay.
Yes, sir.
Okay, go ahead, no problem.
Yes, sir. He's immunized as per NIS. BCG scar present. Last vaccination was at 10 years of age.
What is the age,
Nutritional.
what is the age of child?
Sorry, sir. Last vaccination was at 5 years of age. So this I
Yeah,
forgot.
because child is 8 years old.
Yes, sir.
Right. Okay.
Nutritional history. This child like takes almost adequate calories and adequate proteins.
Fine.
Family history. This is the pedigree chart.
Yes.
Socioeconomic, he lives in a paka house, well ventilated with cross ventilation present, separate kitchen and bathroom, no pets, no cattle. He belongs to lower middle class according to modified Kupuswamy scale. There is history of father demise 3 months ago due to liver failure, secondary to chronic alcohol intake.
Right.
So to summarize, this is an 8-year-old developmentally normal child who presented with 20 days history of involuntary movements characterized by asymmetric, non-rhythmic, purposeless movements involving predominantly the upper limbs and trunk, more on the left side, associated with orofacial dyskinesia. The movements were absent during sleep and aggravated during wakefulness. History was associated with swaying gait and slurring of speech. There was history of recurrent upper respiratory tract infection with intermittent sore throat prior to the onset of symptoms.
Okay. Can you stop sharing?
Yes, sir.
Again, I request this student that keep your video on. I don't know. I think that also requires some understanding that why they are hesitant to keep the video on. Or I will say you should not be reluctant. You should not be afraid of that some question will come to me. No problem. I think question comes even if you wish to answer, you can. But please, Dr. Khushi, Dr. Kirti, please can you keep your video on? So many other students, Dr. Teja, Dr. Jyoti. I think you should consider my appeal request. That is just for, I will say, good interactions. We can have the answer. Anyway, I think here she mentioned one of the points that the school performance. Dr. Kirti, I would like to ask the questions to you.
Dr. Kirti is a neurologist for this
Oh,
case.
madam. So I think that it is on the contrary, it will be difficult for me. Madam, what I can suggest that please motivate your students for the interactions.
Yes.
And when we discuss, I think something, because you are neurologist, you can add, suppose some part is really required. Anyway, that's why actually I requested Dr. Nikhila to identify these students so that I can address them properly. Dr. Abhishek, can you come on? Dr. Abhishek? Dr. Teja?
Sir,
Yeah. She mentioned that regarding some school performance. I think I would like to ask the question, can you name some conditions where the school performance may be affected and there may be the complaint? Some of the disorders in our practice, pediatric practice.
Wilson's.
Okay. Maybe one of them is the Wilson. Can you always, Dr. Teja, the medicine, remember the common causes first. Why I'm coming to the point, suppose I'm sitting in the OPD and mother comes with the complaint that there is some remark from the school that school performance of this particular student was good. But since last few weeks or months, some very vigilant teacher might note that the performance of the student is deteriorating.
ADHD.
And then they will inform you. Yes, very good.
Learning disabilities.
Absolutely, very good. So autism or even the attention deficit, hyperactive disorder, that can also present. Any other still more common? With the severity of the problem? Yes, somebody has put this severe acute malnutrition, but most commonly the iron deficiency anemia.
Nutrition anemia, sir, yes.
Why we miss it? Even megaloblastic anemia. What somebody was talking, I will say anemia Tabor syndrome. The older child may present with this, the school problem. Right. So even this school, even this sometimes, early stage of tuberculosis, CNS tuberculosis, that may present with the personality changes, school performance. Right? So even Wilson disease, somebody said. One more CNS complication, late complication of some vaccine preventable disease. Let me give some hints. This condition is following some infection, viral infection in the early childhood. Yes, somebody has put on the chat box, very good. SSP. In SSP also, there are the various stages. Initial stage, never we come to know that exactly the SSP. There are the vague symptoms. There may be some problems of gait, frequent falls, or even just a school performance problem. It's a chronic infection. It's a chronic disease. It's a slow viral problem. And therefore may not present as the acute encephalitis syndrome. It has the various stages. And that initially with the stage 1, that will be the vague symptoms. Nobody can suspect, I will say, immediately the SSP in the first presentation. Then gradually some myoclonic jerks or some characteristic develops. That may draw attention, that some multiple marks over the forehead. And when you ask that why it happened, and then you understand that, oh, that is the myoclonic jerks. But before that, what is my idea? As a clinician, when you are sitting in the OPD, you don't know that what is the problem with the child. And therefore, child may be the simple anemia. If you treat it, becomes fine. May not be even beyond that. Megaloblastic anemia, B12 deficiency can also cause a neurological problem. Or really, in true sense, there is some neurological condition like Wilson disease with the basal ganglia involvement, or even with this type of the SSP, various conditions which, in short, that's why my idea that better to keep in mind. How the domperidone is a very common mistake which I have found, and at least 2 cases I have observed, being the practitioner, that due to the domperidone, the child presented with the dyskinesia, which is one common mistake by the practitioner or even the pharmacist, which creates the problem. Anybody? Unless you have attended or you have seen, if you have come across. Let me ask the question in some other way. Dr. Teja. Very simple question. To be very frank, I am very basic general pediatrician. So my questions are not going to be too complicated. That we'll ask Dr. Kirti, because I am not the neurologist. But whatever the common conditions I have come across, and being first we should be the good general pediatrician. What are the strengths available of domperidone in the market?
Suspension domperidone.
Very good. What is the concentration of the suspension?
1 ml contains 1 mg.
Very good. And what is, another preparation of this liquid preparation of the domperidone?
Drop.
Liquid preparation, drops. And what is the concentration in the domperidone drops?
I think.
This is the question. That means whether you work in the ward or not. Somebody is putting very nicely 2 milligram per 5 ml. It is the drops. So concentration will be usually in the ml. This is 10 milligram per ml. 10 milligram per ml. In suspension, 1 milligram per ml. I remember one 8-10 years old girl presented to me with some abnormal movements of shoulders and eye abnormal. That somebody, neurologist even said, oculogyric movement. Somehow that patient came to me. I was also not able to answer immediately that what type of the CNS problem it is. Mainly oculogyric movement. When I asked in the history of that, she had some simple vomiting due to some food. That practitioner, general practitioner, just prescribed the domperidone liquid. He didn't say drops, he didn't say suspension, and therefore the pharmacist dispensed drops 10 milligram per ml. And the dose given by 5 ml 3 times a day. 5 ml, that means how much you'll go, 10 milligram per ml. So every time 50 milligram. 3 times a day, that means 150 milligram per day. Now, if you know the dose of domperidone, and if you calculate, it is quite high. This is, I will say, probably about a year. I saw this patient, just stop it. Otherwise, you know that we'll go for MRI brain, neurology reference, so many things, even so many, consider even the immune disorders, autoimmune disorders, CSF titers, right? So that's, I will say, beauty of the history. That's the point which I wanted to highlight, that please go into more details of them. Many a times, most of the times, reasons are this simple. Every child does not present with the rheumatic chorea or SSP or Wilson. Their presentation is not so common. They are rare for the general pediatrician, maybe common for the neurologist. Therefore, always go in the details of the history, and I'm sure that that will give us the various ideas regarding the cause. Now, having this condition, always the DNB and MD examination. I think this Dr. Nikhila is doing the MD, DNB. Am I right, Dr. Nikhila? Are you DNB
Sir.
student?
Yes, sir, I'm DNB student.
Yeah. In the DNB and even MD, the people are always asking the examiners that the summary from the history. And summary should not be the repetition of the same story which we have discussed. Summary, that means a capsule form, your interpretation, your inference, or hypothesis. Naturally, from the history, probably we may not be in the position to give the diagnosis. But we can give the good, our interpretation. And in the CNS case, always try to answer that which part of the nervous system is affected. Always try to locate the anatomy first. Second part, you try to answer that what is the likely pathology. That means what type of pathology? It is infection, it is inflammation, it is traumatic, it is vascular, it is immune disorder, it is degenerative disorder, it is some storage disorder. So many CNS disorders can be there. So out from the description of the story, try to understand that what is the possible pathology which has caused the damage to this particular part of the nervous system. And third, put the common etiological conditions. You can put the common conditions, and that should be the good summary. I gave some idea that how you should prepare the summary from the history. And it is said in the neurology, I will say in any system, more so in the neurology, that 80% diagnosis should be revealed from the good history only. Good history should be able to answer all these questions which I raise. And most of the times you are right. Of course, we know the medicine, every time we may not be right, but most of the times we are right. And even it is said that suppose if you are not right, go back in the history, that is something we have missed. Then we realize, oh, this point I missed, and therefore I could not understand. That's, I would say, beauty of the history. And therefore we are insisting even in this era of advanced technology and AI also. AI is not going to be so advanced what probably the human brain is going to be. Of course, you can take the help of the advanced technology, but please don't become the dependent on this advanced technology. Then our deterioration will start. It's very important. Having this remark, I want the help of some of the students to give the short summary. I will request 2 students, voluntary, they should come forward. That in these are the concept, try to answer that what is your summary. What part of the CNS is affected, and that with a very good explanation that's why I say that this part is affected. Explain the pathology and put the common etiological conditions. With that, Dr. Teja, can you make the attempt? Make the attempt without any hesitation, please.
8-year-old developmentally normal child with involuntary purposeless jerky movements involving upper limbs and trunk, associated with slurred speech and coriform like gait,
Right.
which movements decrease during the sleep,
Yes.
No seizures, altered sensorium. So
Very good.
findings mostly suggestive of Sydenham chorea, probably due to basal ganglion involvement.
Okay. Then you are really master clinician that you did everything. Which part is affected, what is etiology, what is pathology, what is pathophysiology, good. But you know, this happens sometimes in the exam because you know the case. But if you, when you don't know the case, I think, we will try to predict something. We'll try to consider the common conditions. But anyway, I will appreciate your good attempt. Dr. Fatima, can you take it? Yes, Dr. Fatima? Or Monica, would you like to put the summary in your own way? As a teacher, I'm learning that always we should have the patience. Always the students are having reluctancy, hesitation, some apprehension. So we should not force them. But we can motivate them, we can encourage them, and then gradually they will speak. So Dr. Monica, I will keep the sufficient patience, but I will wait for your response. Anybody? If Monica is not ready, somebody else? I'm not sure whether Dr. Riya Patel is from faculty or the student. Please. Dr. Riya, can you identify yourself? Dr. Jyoti, I know that Jyoti is from Hyderabad. Jyoti, what will be your way of putting the summary? Anyway, then let me put. Always, as I said, summary should be very short and sweet, very meaningful. That should be, I will say, interpretation of the whole story which I understood. Okay, Dr. Riya is BCS student, first year. So she is from Valsad, Gujarat. Dr. Riya, would you like to put the summary in your own way? Or you, because you are first year, you want to wait? Anyway, no problem. You can try later on. So how we can, I think from the description already we have discussed, you can say that here 8 years old boy has presented with very specific movement disorder. Going with the details of movement disorder, certain characteristics, that it is the involuntary, passive movement, involving particularly even the limbs, extremities and trunk. Even the orofacial involvement is also very common, with emotional lability already, which she has mentioned. And so it looks that very classical, the choric movement. With the choric movement, even she is finding the difficulty in walking, even speech is also affected. Having these multiple issues with the preserve, even the absence of seizures, and maintenance of the good consciousness, probably there is no cortical involvement. But as I cannot rule it out, even the cerebral involvement, because similarly, some points are even overlapping the cerebral involvement as well as the basal ganglia, particularly the tone and speech and other things. That's why you can put even consider in this way that involvement of either the basal ganglia or cerebellum. Looking at the pathology with the fever and cough, I'm not sure, even it can be the viral precipitation by the viral, that it can also happen like cerebellitis following some viral infection, or even having some infection viral past and later on this inflammation, that is immune mechanism, can also occur. Difficult to say regarding the pathology, but certainly it is not due to the probably trauma, less likely infective, vascular is out of question, or even any other degenerative disorder is not possible. Metabolic again cannot be totally ruled out. Less common, but still I would like to keep in my differential diagnosis. Regarding etiology, probably it requires further details of examination and necessary investigation for confirmation. But in simple language, I can say that it's a subacute, slowly progressive disease, particularly involving the basal ganglia and possibly cerebellum. Most likely either the viral or some immune disorder. I'm sure that if you put it this way, most of the examiners will consider us. I think before we go for the examination, let me take a word from Dr. Kirti, because she's neurologist. I'm sure that her comments will be very important for us. Dr. Kirti, please, madam.
Yes, sir. As you have rightly put, that it is a subacute onset movement disorder. Whenever and by the characterization of the symptoms, we are come close to that it is chorea, because by the description it doesn't look like dystonia. There are no twisting movements. In dystonia we have more of abnormal twisting postures and abnormal sustained contractions of the flexion and extensor muscles.
Different group of muscles, yes.
Yeah, so that gives abnormal postures and twists. So that goes in favor of dystonia. So here this child is more having a dance-like movement. And one more comment about chorea is that they have flowing movements. The movements flow from one part of the body to the other part. They are continuous. Many a times, tics are difficult to differentiate from chorea. Many times, tics and chorea get confused. But one point here is tics are intermittent. They do it, stop it, again do it, stop it. Chorea is more continuous. They go on continuously. So that is one differentiating point. And so I think subacute onset chorea in a healthy school-going child without any prior developmental issues or intellectual issues. We would like to keep infective causes first, infective, inflammatory, autoimmune, and endocrine metabolic causes. By metabolic, I mean electrolyte disturbances like hyperglycemia, hypomagnesemia, endocrine disturbances like hypothyroidism, hyperthyroidism.
Yes.
And then very less likely to be genetic or the neurodegenerative.
Absolutely. Very good. I think what Madam said, that how we should be our thought process, that always keep the common conditions first, then the less common, and even keep the rare, because naturally from the history we cannot rule out everything. But that will be the thought process, and that will be quite rewarding. I think let me ask some other questions as it may examiners may do in the exam. Dr. Teja, can you keep your video on, please? Dr. Teja or Dr. Monica, because you are responding very nicely.
So no electricity here, sir, just very dark.
Okay, Monica, no problem. What is my question? Suppose somebody is asking the question in this way, that this was a 12 years old female, and 12 years old female has presented with this type of the movements. On examination, or even parents also might complain that yes, there was some skin lesions also. And on examination, I found that she is hypertensive. She is a female child. She is 12 to 13 years old female, presented with these type of CNS movements, like what I mean to say, choric movements. But yes, Dr. Teja, very good. So you know what I mean to say, that is an even remote uncommon condition. But suppose if you get some skin lesions, particularly very specific malar rash, or even the alopecia, or even the oral ulcers, you know, every patient may not have it. As a clinician, we'll have to find out some important clue. Or even suppose on measurement, there is a siege hypertension. Somebody has done routine urine examination, and if you got that, oh, there was albuminuria or hematuria. And then if you put all the points together, then which looks like the rheumatic chorea to me, I will say, oh, it's not rheumatic. So as a clinician, we'll have to keep all the points in your mind. Then even
The psychosis
SLE,
also, sir, in this
psychosis,
patient.
yes, it can present. But every symptom may not be there classically given in the
Yes,
table in the next one. If it is there, nobody will miss it. Nobody will miss it. But
Right.
every patient may not have this manifest. I remember in our ID chapter, infectious disease, where we are frequently discussing, I think few weeks back only we had one patient. Everybody was talking it's a tuberculosis, CNS tuberculosis, it's a tuberculosis meningitis. But points were not satisfying. Even CSF was not helping. Even once somebody did the MRI was not showing anything. But when that particular girl, that was 12, 13 years and going on since, I will say, few weeks to months together. It was going on since months. And the hypertension was there. And urine examination, somebody just, I will say, slide was presented and noted that there was a significant proteinuria and hematuria. Immediately we said in the discussion that there is no question of infection. It's a SLE. And friends, believe me, on further workup turned out to be the SLE. Actually, what I want to share with you that as a clinician, a very classical picture is there. Most of the times it is not missed. But when the classical picture is not there, and every patient does not present with the classical picture. So always as a clinician, in short, go for the lateral thinking when you are not happy. That is the point, I think, which I wanted to emphasize. Now, one more point before we go for the examination.
Sir, I want to ask one question, sir.
Yes, Monica, come on.
They're
That's good.
quasi-purposive. So these are quasi-purposive movements.
Yeah.
Coriform movements are quasi-purposive. So we can ask the parents also that when the patient just tries to, that movement happens and then the person tries to perform, okay, I was doing this thing or that thing. Is it, sir? So can you explain this, sir, quasi-purposive?
Yeah,
The type, the definition.
Quasi-purposive, that means, so when most of the times even, suppose in a case of cerebellum, what happens? That is the intention tremor. That person is trying to pick up something, or then the tremor increases or may even be revealed. Similarly, even in some other conditions also, that by action, that is very specifically precipitated or maybe exaggerated. Here, I think without any purpose, without anything, just continuously it is going on. That is the characteristic. And classically during sleep, it disappears or maybe minimized. Most of the times it disappears.
Yes.
So that whole description will give the idea.
Right. So thank you.
So that's the thing that I, anyway, Monica, my question to you, that now we have discussed this patient in the history details.
Yes, sir.
This type of the question is going to be there in the exam. Some good examiners, methodologically, if they want to assess you, now they will say that before you examine, what you are expecting on examination, that these findings should be there. Or specifically, we will check whether this finding is there or not. So what you will check, or what you are expecting that it will be found on examination. Starting from general to systemic. On general examination, what you should check and what you are expecting to get. And then on CNS. What you should check specifically? Come on, I think various things are there. Let me ask the question. If you don't come with your thoughts, I will ask you the question. What you're expecting on the vitals? Naturally, first we'll check the vitals. Do you expect anything in the vital derangement? That means temperature, pulse, respiration, blood pressure, SpO2.
Sir, can I request you one thing, sir?
Yes.
I have my PG. Sir, I am from Medical College, Jabalpur. I have my few PGs there, sir. Can you ask them, sir?
Dr. Monica, are you faculty?
Sir, I am a faculty, sir, but here, sir, there is no, network is very on and off going.
Okay.
So
can you identify your friends?
No, PG, sir, Dr. Ankita, Ranjit, Jayas.
Yeah, so I think they should come. Come on. Very good. Dr. Ranjit, would you like to,
Sir,
Dr.
here
Vinit?
the weather is very bad actually. Right now.
I understand.
Thunder, lightning, no, sir.
No problem.
So
Dr.
I'm
Vinit, I hope that you were there from the beginning. You know the case? Or anybody? Dr. Ranjit. Dr. Ranjit. Dr. Teja, would you like to make the comment on examination? You know, I think how you can expect the examination findings, that probably you make up your mind with the various possibilities. And that in these conditions, what can be the findings? That you will check it. If it is there, that will help you for consideration of that possibility. And suppose if it is not there in something, but you should know that what you should check. I think Dr. Ranjit is trying, but there is some disturbances of the net. So, yes.
Sir, in higher mental functions.
Yeah, very good. I think Ranjit, before that, let us start from general examination. From the vitals. Vitals, do you expect anything abnormal in this patient?
Sir, it is if chorea is associated with any cardiac involvement, there will be signs of CCF.
Do you expect this? Why the chorea should have the heart involvement? What is your idea?
If we suspect acute rheumatic fever, then
I think Dr. Ranjit, commonly, if you know,
yes,
that chorea commonly presents as an isolated rheumatic chorea. I am talking.
Yes, sir.
Sydenham's chorea. That chorea usually does not present commonly with this carditis.
Yes,
Most
sir.
of the times, even the history of suppose rheumatic in the past or even sore throat or something is probably missed, not noted. Even parents may not be aware. And straight away at 10 to 12 years, more common with the female, they present with the rheumatic chorea. And therefore, in the Jones criteria, if you know,
yes, sir,
that for diagnosis of rheumatic chorea, there is no need to satisfy this Jones criteria. Do you know this point? The reason is because with this rheumatic chorea, we are not expecting that some signs of carditis or arthritis or something will be associated. Most of the times, rheumatic chorea presents as an isolated condition. Right. So usually, I think you can, in the exam, suppose by chance, if this particular patient, I'm not sure, but if present with the cardiac involvement, I will say that commonly in the vitals, I'm expecting should be normal. Then the vitals usually are not affected. Reason is, you know, the respiratory system is normal, cardiac, therefore perfusion, hypooxygenation is normal, therefore vitals are going to be normal. Right. Okay. What other things you will get on examination? Suppose if I ask you, what will the posture of this patient? 8 years old boy, what will the posture? Because you know, such a patient may not be able to sit properly, steady. If suppose sitting, then also balance is not maintained, not able to walk properly. Right?
No fixed posture.
Yeah. So that will be the observation. Second, but then what else? Even
and purposeless movements.
Yeah, purposeless movements, Dr. Teja. What else? You will observe. Even you will check. Particularly what, suppose if I want to rule out this Wilson, I will check for the jaundice. Usually even in Wilson also, neurological presence in older children and the hepatic involvement may not be there in the past or even maybe. But you should check for any sign of the jaundice or even you should go for eye examination for even the KF ring. You should check it. Right. Similarly, even you should know that you will check for any signs of meninge irritation, neck stiffness, chronic signs, something, maybe in CNS probably, but here, examination of liver, even somebody mentioned telangiectasia, okay? So these are the points which probably you will check. On CNS, what you are expecting? Dr. Ranjit. You started with the CNS. So what
yes,
you will check?
Sir, we're starting with higher mental functions. The cognition is impaired, sir.
Okay,
Emotional liability.
very good. That is the thing. That is a common one, and that may favor to me. What else?
Sir,
No,
poor
very-
scholastic performance.
Yes. That may
Poor
give the
handwriting.
history. Yeah, on the contrary, ask that boy to write down on the paper.
Poor handwriting. Yes, sir.
Sometimes you know that for improving your deterioration, you should have the handwriting at certain intervals multiple times. And that will give the idea whether the handwritings are improving or deteriorating. That may be the simple, I will say, guide to me to assess whether it is improving or further really deteriorating. So that is very important. Speech problems, yes. What else? Very good. So these will be the higher functions. Do you expect any cranial nerve involving this patient?
No, sir.
Very good. Yes, Dr. Teja, I am not expecting. And suppose by chance if it is there, that is something surprise to me. And then I will think something else. Suppose seventh nerve palsy is there, some weakness on one particular right or left side, that means it is something different rather than the chorea, rheumatic chorea particularly. Basal ganglia involvement that can be a case of tuberculous meningitis. Suppose seventh nerve involvement is there, right? So that it will be different. Okay, now what happens in the motor system? Dr. Teja. In the motor system, what you will get? What happens to the tone?
Bulk mostly will be normal, sir.
Yeah, nutrition will be normal. Very good. Then what happens to muscle tone?
Tone mostly hypotonia.
Hypotonia, very good. Then
Power
involuntary movements, yes, it is going to be there. What happens to coordination?
Coordination
will not be possible.
Not possible.
With this, yeah, coordination is going to be involved. Will not be normal. So that means muscle tone, hypotonia, incoordination is affected, involuntary movements will be seen, muscle nutrition will be normal. Right. Sensory you are expecting normal, signs of meningeal irritation absent, cerebral signs specifically you should check. Because some conditions associated with the basal ganglia, cerebellum can also be involved. And for that reasons, please remember the 10 signs of cerebral involvement. Starting from even the head to toe, you can remember and you can check it. Right? Gait is going to be affected in this child. Skull and spine is going to be normal. So in short, in this patient, what you are expecting that higher function to some extent, even the emotional problem will be there. Cranial nerves normal, hypotonia, even hyporeflexia, and even the coordination will be affected. Involuntary movement is going to be present. What I describe in the history, I will confirm whether the same or different movements are there. And then gait is going to be affected. Yes, speech is going to be affected. So these are going to be the findings. Why I am coming to this point, the good clinician, it is said that before examination can describe you the findings, more so in the neurology. That was my idea. That again will we go back to Nikhila, presenter.
Yes,
Now
sir.
now you can go for the examination. Dr. Nikhila, please.
Yes, sir. Examination. Head to toe, this child was alert and active. He was maintaining eye-to-eye contact, interacting well, responding to verbal commands. There was mild pallor, there was no icterus, no cyanosis, no lymphadenopathy, no edema. Hair was black and lustrous, no subcutaneous nodules were appreciated. Genital examination was normal. Going to the
Can you go to previous slide?
Yes, sir.
Any spelling mistake did you notice? In genital examination? Nikhila, you know, the examiner is going to note so many points, not just, I will say, your presentation or your knowledge also. You know, bilateral, yes, Dr. Kamlesh, senior pediatrician. You know, you said test the bilateral, that means both the testes. This is singular. Once you mention it is plural, the spelling is changed, right? So even note these small points also, it makes difference in your identity. Good. Please go ahead.
Vitals, the heart rate was 110 beats per minute, which is little higher for the child. It was like regular rhythm, normal volume. There was no radial delay, assessed in right radial artery. Respiratory rate was 20 cycles per minute, bilateral equal movement of the chest. Saturation was 98% at room air, and BP was 107/60, assessed in right brachial artery with appropriate size cuff in supine position, which was normal for this age.
Right.
Anthropometry, this child is like height is falling between 50th to 75th centile. Weight was around 75th centile. BMI was 17.8.
So what is your interpretation? Always, in the
Sir,
as a PG
this-
student, put your interpretation with the growth chart.
Yes, sir. Sir, according to BMI, he's falling like between over, like near to overweight, sir.
Is it?
Yes, sir. Like according to the chart I plotted.
Okay. Anyway, but right or wrong, but what I mean to say in the exam, perform 2-3 things, please remember. One is very appropriate measurement of all the anthropometry. Very precise. That is very important. So in endocrinology, the first requirement that your measurement is very accurate in even the very proper decimals. Next point is plotting on the growth chart. Very rightly plotting on the growth chart. And then try to interpret it properly. That is it starting from that is normal or abnormal. Suppose abnormal, what is the abnormality? Whether height is affected, weight is affected, whether both are affected, head is affected. And in what way then as a whole try to interpret. And then try to derive that what type of the disorder it is. Does it indicate malnutrition? Does it indicate some short stature? And that is the short stature again from the growth chart you can say whether it is really constitutional or really it is indicating some endocrinal disorder. Really it is obesity. So that is for the postgraduate. Please, it is very, very important. Not only for the postgraduate, I will say daily not practice. It is nowadays said that for endocrinology case also, investigations are not required routinely, better of investigations. Investigations at the end for confirmation of your clinical diagnosis. So the growth chart is very important in, I will say, every condition with the pediatrician. Sure, on the contrary, what I will take it, that with this good, even the weight and height, on the contrary, little bit what Dr. Nikhila said, that higher side, that means the child has not any nutritional problem, not only nutritional, but no any chronic disease. Suppose any chronic disease like Wilson, child is not going to allow to grow properly. It's a chronic liver disease. It's suppose some chronic kidney disease. So certainly from this growth chart, you can make out that this child is nutritionally good. On the contrary, towards higher side. That is certainly the nutritionally and even from the any endocrinal or any chronic disease point of view, child is out. This is the really power of the growth chart. As a clinician, we'll have to find out that not just plotting. Undergraduate, I will say, in the exam, undergraduate just shows me the growth chart, I'll be happy, even just showing. But for the postgraduate, all these, I will say, steps and come out with your interpretation exactly. I think in every case, this is not only for Dr. Nikhila, but all the students, and even I will extend that even to all the practitioners. Okay, Dr. Nikhila, take it further. But I'm sure that this message is very important.
Yes, sir.
Very nice. Please take it further.
On systemic examination, higher mental function, this child was alert and active, oriented to time, place, and person, obeying commands, interacting well, alert according to AVPU scale. Cranial nerve examination was normal.
1 minute. Again, Nikhila, go to the previous slide.
Yes, sir.
Before that even. Yes. Next. Yeah. Now here, once you said everything, what way you described, alert, active, orientation, obeying commands, interactive, where there is no need to mentioning AVP scale or the Glasgow Coma scale.
Okay, sir.
No need, on the contrary. When you will go, that when there is some level of consciousness affected, impairment of consciousness is there, then I want to define the level, severity, rather than level, severity. Once it is normal, there is no need to mention Glasgow Coma scale or AVPU. It's normal, means normal, right? So that they come in the picture once you say that yes, consciousness is affected or it is impaired. Then I would like to know up to what level it is impaired. What is the scale? And in that case, you will go. You know, even the AVP is also not for this type of, it is in the I would say ICU for the rapid assessment. Because Glasgow Coma scale takes more time. And when I am not able to spend the time this much for the Glasgow Coma scale, and hurriedly I want to decide whether following trauma, a child is brought to you with this some road accident or something, I will not be able to go to Glasgow Coma scale in detail because it is time consuming. Just I will check regarding the alertness of the patient and verbal response and response to pain. That's all. And I will try to decide roughly that what is the level of this consciousness, right? But in this patient, this is not applicable. That's why even your presentation should be very intelligent. That perfectly you mention, relevant, I will say, related to your particular findings and case you will mention, right? Again, this is very important, I will say, for all the students. Yes, Nikhila, take it further.
Yes, sir. Cranial nerve examination was normal.
Very good. But I think you have mentioned very nicely. Just can you go through it for the sake
Yes,
of
sir,
other
sure,
students?
sir.
Suppose in the short, if you have to go for CNS examination, particularly for the cranial nerves, which important point for each cranial nerve you will find out, and you can go for the interpretation whether it affected or not. Please.
Second
For
cranial
the
nerve.
first, okay, yeah. Second.
Yes, sir. Second cranial nerve, we can check fixation and eye light reflex present or not. So this was normal in this child. And for 3, 4, 6, we can check extraocular movements which were intact in this child. For cranial nerve 5, we can check chewing movements.
Please remember for the optic nerve 4 points.
Yes,
Acuity
sir.
of vision, field of vision, color vision, fundus. And
Yes,
light
sir.
reflexive, just to verify it. So
Yes, sir.
these things should come in the order. That acuity of vision is normal. Field of vision, whatever by simple method you have used. Color vision,
Yes.
okay, if you have checked, and fundus is normal, light reflex, normal. That's all.
Yes.
Okay.
Yes, sir. For cranial nerve 3, 4, and 6, extraocular movements were intact.
Yeah.
For cranial nerve 5, facial sensations were intact, chewing movements were present, and corneal reflex was intact.
Good.
For cranial nerve 7, nasolabial folds were symmetrical. There was no deviation of angle of mouth, and frowning was present.
Yeah.
Cranial nerve 8, the child could localize sound. And cranial nerve 9 and 10, swallowing was present.
I think
Cranial nerve 11.
here you can mention something more also. Suppose not just swallowing. Swallowing is present, no nasal twang, uvula is central, and gag reflex is normal.
Yes, sir.
Very simple, but that will include everything 9, 10 very appropriately. Okay, fine.
Okay, sir. Cranial nerve 11, the child was able to turn neck from side to side, shrugging of shoulders was present. Cranial nerve 12, there were no fasciculations of the tongue or there was no atrophy was noted.
Very good. So I think in the exam point of view also, please, you should be prepared because, you know, in the defined time, you'll have to go for the whole examination. So this is good even in the short to describe all the cranial nerves. Okay, fine. Nikhila, take it further.
Yes, sir. Motor system, he was in supine position like few minutes and he was wandering here and there. So like being given time, his tone was normal.
Yeah.
Power was normal. But he was constantly moving.
Right.
deep tendon reflexes were preserved on both sides.
Okay.
And sensory examination, superficial and deep sensations were intact. Cortical sensations, the child was not so cooperative to examine.
Nikhila, again, for the presentation point of view, go to the sensory system. The always headings first, the cortical, superficial, and deep.
Okay, sir.
Always we go for the cortical first, then the superficial, then the deep. Okay.
Yes, sir. Yeah.
And Devak, you could not examine cortical sensation?
Sir, like he was not sitting at a place, sir. He was moving here and there, and he was
Suppose if
not.
you ask the child to close the eyes and give them some coin, I'm sure child will be able to say it's a coin, or even if you rubber or pencil or something from the shape even person can identify. Anyway, the point is, sometimes try to go for some common. Okay, 2-point discrimination may not be possible probably, but
Yes,
some stereognosis, identifying the common objects. Anyway, good. Take it further.
Yes, sir. Movements, there were cornuform movements present, predominantly involving both hands, and majorly the left upper limb was affected.
Right.
These are the videos of the child. So can I take it further, sir?
Yes. I think just we wanted to show the video to all the students, and it is good in the presentation because when you are going for the online presentation, take some pictures, take some videos. Of course, please don't miss to take the consent of the parents because now it is very important. Fine.
Yes, sir.
Okay, Nikhila.
This child was having stereotypic movements of the lips and facial grimace was also there.
Right.
Milkmaid's grip was also noted.
Good, I think good signs you have elicited. Anyone captured in the videos?
And then this was the gait of the child.
Is it waddling gait?
Yes, like
waddling gait have develops in which type of the conditions? Basic pathology with the waddling gait is?
Cerebellar lesions.
No, it's not waddling gait. That's why.
Yes, sir.
Another thing I would say, please remember in the theory sometimes they will ask you the various gait disorders. And waddling gait, once you say, it is very specific, not even ataxic gait. No, it is not ataxic gait. Here, you may call it the ataxic gait in this patient. But waddling gait, that is the weakness of the gluteus medius muscles. And commonly seen even in the myopathy, not even the nerve injury. Nerve injury is quite different, Dr. Ranjit. Waddling gait is the characteristic of myopathy. And that myopathy, maybe even in a case of even the DMD, I will say Duchenne variety of muscular dystrophy, yes, you will get the waddling gait. Or even the old age people, due to the weakness of the muscles, and particularly the weakness of the gluteus medius muscles, that there is a tilting, I will say, gait will be there. That tilting, I will say, the iliac bones. That one side iliac bone is going up, another is going down. That is the waddling gait. And that is a very characteristic of, I will say, muscle atrophy or muscle dystrophy, particularly the involvement of gluteus medius muscles. I'm sure that you can check it. That is very important. And here I think it is, child is not able to walk on one particular steady line. And therefore you can call it, I will say, even the ataxic gait or even the swaying while walking. And that indicates, I will say, the involvement of either the cerebellum or even the basal ganglia, that is which happens in a Parkinsonism. It is something different in Parkinsonism, but the gait is involved even in the basal ganglia also. So, okay, but the video is good. Fine. Take it further.
Yes, sir. Cerebellar examination. posture was normal. Scanning type of speech was noted, and swaying gait was there.
Right.
Tandem walking couldn't be performed. Finger test was
Yeah,
normal.
that's why I mentioned he was not able to walk straight on one particular
Yes, sir.
line. That is the
Yes.
tandem, I will say, gait, tandem walking. Yes.
And rhomboxane couldn't be elicited, sir.
Fine. So,
Others is-
your point was some cerebral signs were present, right? According
Yes,
to
sir.
you?
Speech.
Because speech is there, swaying and even tandem walking is a characteristic of. Anyway, okay.
Other systemic examination, on CVS examination, precordium appeared normal with no visible precordial bulge, scars, or dilated veins. Apex beat was palpable in fifth left intercostal space, just medial to mid-clavicular line. First and second heart sounds were normally heard. There was pansystolic rumbling murmur, which was grade 3, audible in mitral area, predominantly over the apex. On respiratory examination, there was bilateral air entry, normal vesicular breath sounds were present. Per abdomen was soft, non-tender, and no organomegaly was noted.
Right.
To summarize,
CVS, what you are finding, can you just take the further? Precordium, normal.
yes, the precordium was normal,
No
sir.
vision. Apex beat was in the fifth intercostal space. It is normal, just medial to the mid-clavicular. That is normal.
Yes, sir.
Heart sounds were normal.
Yes, sir.
Intensity normal. But you got the murmur?
Yes, sir.
Systolic, okay.
Yes, sir. Yes, sir.
That murmur was there, grade 3. Mitral area over the apex. That means the systolic murmur was there in the mitral area.
Yes,
With
sir.
this type of the presentation, we should be very careful. Anyway, this whether does it indicate, because commonly what I understand that carditis and this chorea together, I think it's not the normal combination in a case of rheumatic. Unless
Yes,
I think echo or some other, you can take the help of other, I will say, criterias and may come to the conclusion. Okay, next. You have anything in presentation? Summary.
Yes, sir.
I think what is your summary you can put, and then we'll go for the discussion.
Excuse me,
sir.
Sir, excuse me.
Yes, Dr. Monica.
Sir,
Yeah.
apart from milk braid grip, we have the other signs: sagging
Yeah.
sign and spoon deformity
Yeah,
and serpentine tongue.
right.
That also we can look into
This was kept for
in
Monica.
Korea.
Monica, purposefully, probably your
Sorry
friend
for-
kept that the
sorry for
Monica will discuss. You are right. You are right. Absolutely right. Good.
Thanks.
On the contrary, I thought that after stop sharing, we'll go for the discussion, and I will raise all these questions. And what are the other signs of
Oh,
Korea?
sorry,
But
sorry.
no, but you remember, it's a good thing. It's a good thing. Good. Whether Nikhila, did you check what Monica asked, whether these signs were present or absent?
Yes, sir. We checked, sir. Like, darting tongue was not there, sir.
But then Nikhila,
Spooning
you
was
should mention what Monica wants
Yes,
to
sir.
convey. She's right. That you should know all the signs of the chorea, and then you can mention which signs are present, which signs are absent. Of course, we believe
Yes,
that all the signs may not be present in one particular patient, but at least even in the exam also, you should mention that I checked, these signs were found, and these signs were absent. So Monica's point
Okay,
is
sir.
valid, quite valid point. Good. Okay.
Yes, sir.
Monica, are you from the same place or different medical college?
From Jabalpur Medical College, Madhya Pradesh.
Okay, Monica is from
Jabalpur.
Jabalpur, naturally. So Nikhila, she's not knowing you or the case. So I think independent thinking is a good thing. Okay. Usually what I do, that you are from the same department, you should go for fighting. Good. Okay, Nikhila, take it further, your summary.
Yes, sir. So this is a case of an 8-year-old boy who presented with involuntary movements involving trunk and limbs with emotional lability, speech and gait abnormality. with no seizures. Like probably from history, we thought it to be cerebellar involvement or basal ganglia involvement. On examination revealed coriform movements with facial grimacing, milkmaid grip, swaying type of gait, with scanning type of speech, and with preserved higher mental functions, cranial nerve functions, tone, power, and reflexes were normal, and sensory examination was also normal. Cardiovascular examination showed grade 3 pansystolic murmur at the apex, could be mitral regurgitation.
Okay. Can you stop sharing?
Yes, sir.
Now I think others should come with the questions. If you have some questions for Dr. Nikhila, other students should ask. Suppose something, if you don't agree with her finding, or something as Monica said, which you are expecting and whether to confirm whether this particular sign was present or absent, something like that. Anyway, so now we can come to the final conclusion. I think particularly with the CNS findings, CNS discussion, we are highly convinced, all of us, that yes, it is the chorea. And with that, likely this rheumatic chorea. Now, what is the comment on the cardiac finding? Anybody, any other student? Dr. Teja, Monica, or anybody else? I don't know why other students are not participating. You should not have the hesitation. Ranjit, what is your interpretation regarding the cardiac finding? Dr. Ranjit?
Yes, sir.
What is your comment with this cardiac finding? I think you know that what she described.
Yes, sir. Yes, sir.
So what
Sir,
is your idea?
she described holosystolic murmur at apical area. Sir, whether this murmur is radiating to axilla, she does not mention.
Okay, you can ask her. No problem. I think whatever the questions are there, you can ask. She will try to answer if she had noted. Dr. Nikhila, try to answer his question.
Yes, so there was no radiation of the murmur, sir. We checked it.
Okay. Ranjit, what is your idea? Suppose if it is radiating, what does it indicate? What is your idea?
Sir, I think, sir, I don't know exactly the reason, but maybe severity.
Okay, in any murmur, you know that at least radiation should be checked. Okay.
Yes, sir.
Anything else? And with this murmur, now what is your interpretation? Normal or abnormal?
Sir, abnormal.
Then abnormality, what abnormality does it suggest? What type of abnormality you can predict from this finding?
Sir, rheumatic arthritis, we mostly mitral regurgitation. We
Okay, why rheumatic?
Sir, if a child has a recurrent upper respiratory tract infection.
I think so many children develop the upper respiratory infections daily in your OPD. How many of them develop this rheumatic? Every day, I would say hundreds of patients, all of us must be getting with these upper respiratory infections.
Yes, sir.
On the contrary, now rheumatic is going down.
Yes, sir.
So simply from upper respiratory, probably we cannot correlate. Maybe your point is valid, maybe right. But I think from that point, we cannot give them more weightage or importance. The reason because so many children present with this upper respiratory, but hardly from that may go for the rheumatic. So try to find out what I mean to say, some solid, very specific explanation, which should be palatable, impressive, convincing to the person. Suppose if I ask an examiner that it may be the innocent murmur, sometimes we may get it. It has nothing to do with this condition, rheumatic or whatever you are thinking. It is just systolic murmur, we get it sometimes, innocent murmur.
Flow murmurs.
Flow murmurs, yes. Dr. Monica is supporting me rather than you. Monica, are you supporting me or your colleague?
You sir.
I think I'm lucky that you are supporting me.
Severity of anemia could be graded, sir, for flow murmur.
So your Monica is coming that it may be the hemic murmur. Dr. Kamlesh also says that may be due to anemia, maybe even the innocent murmur, because of presence of murmur. So direct you are linking with this rheumatic. And if you are linked, in short, whatever your explanation, you should be able to answer. Now, Monica, I think before Ranjit answers, let him give some time for thinking.
Yes, sir.
You said that it is the hemic murmur or murmur due to the anemia. Why not rheumatic?
Sir, because sir, this happens. It takes a long time, sir. This chorea will take time, sir. It takes time.
Whether the
3 months, 6 months.
Whether the chorea
No,
takes
sir.
time.
No, sir. It could be, sir, because if it takes time, sir, if chorea is developed, that means that thing has become chronic. The chronicity of the valvular involvement has been there. So from MR, it could have gone to MS, sir. Mitral stenosis.
Okay.
So then that we should have diastolic murmur then, sir.
How much time it takes to develop the mitral stenosis from rheumatic mitral regurgitation?
Sir, it takes time, sir. More than that.
In other way, if I ask you,
not very sure, sir.
Monica, with the acute carditis,
Yes,
rheumatic carditis, what will be the development, whether mitral stenosis or mitral regurgitation?
No, sir. MR, sir. MR will develop first, sir. It is more common in children.
Very good.
But
Very
if
good.
this condition has come later on, if it has taken time, months or so.
How much time?
So 3 months, 4 months, 6 months.
Monica, not months. Monica, not months, years.
Okay, years, sir. Sorry, sir.
And therefore, commonly it is said that children develop this rheumatic in the childhood. Established mitral stenosis, I am talking, not inflammatory. Mitral stenosis, established mitral stenosis will take even the more, and therefore, usually in the adolescent or adults, you will get it. Adults, you will get it.
Yes, sir.
Mitral stenosis.
Sir, I'm talking about chorea, sir. Chorea, how much time? Sir, chorea will take some time.
The point is, on the contrary,
rheumatic fever. After rheumatic fever, chorea will take some time.
Let me clarify it.
Yes, sir,
your point is valid. You know what happens? Commonly, the patient present 5 to 15 years of rheumatic fever as a whole. That may be the arthritis, maybe the carditis.
Yes, sir.
Later on, it takes years together for established rheumatic heart disease.
Right, sir.
And any patient with a rheumatic, I will say, fever or even the streptococcal infection in the childhood may develop this chorea years to after. That many a times a common age for the chorea is about 8 years, 10 years, 12 years. It is a very late age. And even many a times chorea may be the only isolated presentation.
Yes, sir.
With that may not be the arthritis, may not be the fever, may not be the carditis. But the point is, once you diagnose rheumatic chorea, penicillin prophylaxis is must. Because later on at any time they can present with the carditis.
Yes, sir. Yes, sir.
Second, rheumatic carditis and chorea not common, but yes, they can develop. Not
Yes,
so
sir.
common, but possibility is there. So here, that's why, Monica, I am answering your question. That with this, suppose chorea, if I consider the rheumatic origin, then with this murmur, I will link with the rheumatic only.
Okay, sir.
And therefore, I would like to check whether it is really rheumatic carditis or not. That, and for that reason, you can go even the ECG. You can very specifically echo. Echo will be able to help you a lot.
Right, sir.
Even in the absence of suppose echo findings, consider that this is possible, because once you know in our medicine, you know that once whatever the findings, clinical manifestations you are getting, then other findings will consider associated with that particular condition, unless they are quite different. Here they are not quite different because carditis is known to occur in a rheumatic. Therefore, I will try to link together if really explanation of if the real murmur is there. The only thing, that if it is really active carditis, the heart sound should not be normal.
Yes, sir.
But may not be the active carditis at present. That's why what I consider maybe the rheumatic carditis developed in the early childhood or before some time. Now, along with the child has developed this Subandhi chorea. That is probable explanation. May not be always right our explanation, but I think these are the things which we can think with a reference to our medicine understanding, and most of the times we may be right. So that's why I will say I will not consider this murmur due to the anemia, not due to the hemic murmur or even the innocent murmur. I will consider positively. First, I would like to ascertain that yes, murmur is there. And if the murmur is there, significant, that means more than grade 3 or grade 3 or above that grade 3, then it is significant murmur. And if significant, it is a rheumatic origin. I think that's the thing that how we can consider the clinical medicine. Of course, we'll have to go for confirmation, different things, even the echo, various things. Anyway, I think we are reaching to the end of the session. Also, before that, let us Nikhila. Nikhila, you have some investigations, whatever you have performed? For
Yes, sir. I have the 2D echo videos.
I think please share with us, and then let us see what you are ultimately coming to the conclusion. Only the echo, don't CBC, ESR, CRP, because these things will also help us.
Yes, sir. I have those investigations also.
Okay, fine. So I think, always, this is another thing, Nikhila. Always start from the basic investigations.
Yes, sir.
But I know this, your age group, that problem is with us, not with you. We always want the basic things, then the I will say advantage. Anyway, whatever we have prepared, you can share with us. No problem.
So these are the echo videos. So they were showing mitral regurgitation.
Nikhila, your voice is breaking. Can you take some precaution?
Yes, sir. Sir, is it okay now?
Yes, fine.
Yes, sir.
Can you explain us?
So this is a four chamber view, sir, showing mitral regurgitation.
Yes.
And this is these are the echo videos, sir.
Right.
And then going to the investigation, sir. In the child, ESR was 40 mm in first hour, sir, and CRP was 53. ASO titers were 143.
I think what was the echo interpretation by your cardiologist? Because I am not good in echo. Naturally, I have not learned. So
Yes,
I
sir,
would
yes,
I would like to learn from your cardiologist. What was their interpretation?
Well,
Echo.
sir, my cardiologist told it is moderate MR with eccentric jet, sir. And with my leaflets were not thickened, sir.
Right.
And there was AML prolapse was noted.
Actually, what I mean to say, I wanted to know from him whether he got any findings favoring these active carditis. That means the inflamed valve swellings. From that they can interpret.
Actually, valve thickening was not noted, sir, but mitral regurgitation with eccentric jet was noted in two views, sir.
Then what was his interpretation? That is the point. That is active carditis is there, or this is a mitral regurgitation due to the old carditis.
Sir, our cardiologist thought with correlating with clinical scenario, he thought it could be chronic, sir.
Yeah. Anyway, that's right. Because always that's better to verify it. Okay, hardly it makes difference in the treatment, but active carditis, it makes difference in the treatment also.
Yes, sir.
Okay, go further.
And this child investigations, ASO CBP was normal, sir. CRP was
1 minute, fever was there. ESR was 40, CRP 53. And anti-DNA base was elevated, so that was recent streptococcal infection you can consider. Good.
Yes,
so major, minor, and associated evidence of streptococcal infection, that means fulfills the full criteria for diagnosis of rheumatic. We don't have any agitation, right?
Yes, sir.
Good. Next.
Sir, that's it, sir.
Okay, then can you stop sharing? I think you,
Yes.
you should always go for all the basic investigations, CBC, ESR, CRP, even the streptococcal throat, even the swab culture, right? So anyway, I think now please, at least the last few minutes, I request the students to keep their video on, because this is going to be the very important discussion in the exams. The number one point, you know, that now the rheumatic as a whole is going down. Monica, somebody is going to ask the question. What is the most common acquired heart disease in pediatrics?
So now Kawasaki.
Very good. Nowadays, acquired heart disease, Kawasaki is coming up. Rheumatic is going down. But some time back, I talked, I think a year back or so, that now rheumatic is so down that hardly we see.
Yes, sir.
But later on, I remember that there were, Dr. Alok Gupta, 2 or 3 presentations of rheumatic from different centers. From Thrissur, Dr. Anand Keshwan was there. Another, I will say, so from some eastern part of the country, 2 or 3 presentations of rheumatic in probably 6 months' time. Then I said that this is not so uncommon. Of course, it has gone down, but not so uncommon. And today, again, Dr. Nikhila has come with this, even the chorea. I think chorea, after a long time, somehow I have come across. So, but we can modify our statement. Just it has gone down, but it not become so rare. And in the adults, yes, Dr. Alok, they talk us that they do come across even the established heart lesions, valve lesions particularly. So that's right. Anyway, Monica, somebody is going to ask you, what are the criteria for this diagnosis? Or Nikhila, you must be ready. Dr. Nikhila?
The Jones criteria major and minor, sir. An essential criteria.
Monica has come. Can you, what was the original criteria when it was first devised?
No, sir.
Anybody? I think let me share the history. Anybody know the history of this Duckett-Jones criteria? This is Duckett-Jones criteria.
Yes, sir, right, sir. I had read long back, sir, but I don't remember right now.
Read long. Long back means before your birth, before my birth.
30 years back.
Before Independence Day of India. Anyway, let me share with you. It will be very interesting.
Before 1980s.
Because I know this story from my I will say PG days. Duckett-Jones criteria, first, I will say original criteria was devised in 1944, not that old one, 1944. And how it came even. You know, Dr. Duckett-Jones was from Boston, from America. And during that time, there was a discussion in one of the conferences that nearby centers like Ahmedabad, Baroda, or Bombay, Pune, or Delhi, Chandigarh, nearby centers, one center was getting the more numbers of cases of rheumatic, another center was hardly getting the rheumatic, nearby centers. And there was a hot discussion in this conference, physicians conference. Now, how it can be possible? What is the difference in the epidemiology of the disease? And then it was found that one center was strictly following that unless Aschoff nodule, if you get it, it's not rheumatic. And then hardly you will get the Aschoff nodule. And therefore, many cases of rheumatic were missed. Another center was very liberal in diagnosis of rheumatic. That any case with a fever, joint pain, sore throat, or some skin nodules or some cardiac murmur, then they will say it's rheumatic. So that center was liberal, so incidence was quite high. Another center was very strict, so incidence was quite low. And the chances were at both the center that one center must be missing many cases of rheumatic, another center must be overdiagnosing. And therefore they requested during that time, Dr. Duckett-Jones was the very good physician and cardiologist during that time. somewhere probably around 40. And then they requested the Dr. John that can you guide us that how we should diagnose so that we probably not miss and we may not overdiagnose. And that's the history of Genesis, that how this John's criteria came. And he gave the first criteria, original criteria in 1944. And his original criteria, if we check it, probably there is no erythema marginatum. It was not erythema marginatum, was in the minor. And history of sore throat was major. Later on, for your information, revision has taken multiple times. Second revision was in 1956 by American Heart Association. Later on, revisions were 65, 84, 1992. That means 5 times. And last, Dr. Monica, which you should remember, all the students, is 2015. And 2015 modification is quite important. Now, I want to learn, Dr. Nikhila, what modifications, very important attention drawing changes have taken place in the latest revision, 2015, Nikhila?
Yes, sir. In 2015,
Just you can highlight the
changes.
changes.
Sir, it was divided into low risk population, high risk population.
Very
sir.
good, very good. Please note all the friends. Previously, there was no this type of the demarcation for the low risk and high risk. We are falling in the high risk category. And for the high risk category, they have given some special consideration. I may not go into details, but the cutoff value for ESR, CRP, they have made different compared to the low risk group. Low risk group, particularly the developed countries, but we are falling in the high risk group. And high risk group, again, they are defined from the numbers of rheumatic fever, prevalence of the disease. That again, you can go in the details of the criteria, which is given in that standard textbook. So in short, that is one change in the high risk and low risk. And for that different criteria, some cutoff values are defined. Okay, Nikhila, what is the second change?
Sir, the main difference between low risk population and high risk population major criteria is the arthritis, sir.
Yes.
In high risk population, we consider monoarthritis, polyarthralgia, and polyarthritis, sir.
Right.
Whereas in low risk population, we consider only polyarthritis in major criteria, sir.
Absolutely. So this is very another point to be noted. And third point, Nikhila?
Sir, in minor criteria, in low risk population, it's polyarthralgia, sir. Whereas in
Yes.
high risk population, it is monoarthralgia.
Yes. Even
And
monoarthralgia,
also ESR
that
more
means
than
for
6.
us. Yes.
Yes, sir. And
And what-
ESR more than 60 is considered in low risk population and more than 30 is considered for high risk population,
High risk,
sir.
yes. Similarly,
Yes, sir.
CRP cutoff value, I
These
think,
are
is
the
also
major-
different. Yeah. One more point.
CRP cutoff is like
Yes, yes. What is the cutoff value for the CRP? High risk and low risk?
sir, it's more than 3, sir, but fever is different, sir. For low
Yeah.
risk population, it's more than 38.5 degrees Celsius.
Yeah.
For high risk population, it's more than 38 degrees Celsius.
Very good. Still one more point. Carditis. You know, carditis initially we were diagnosing clinically. Now echo is must. That is for the subclinical carditis. Subclinical carditis, that means clinically there is no evidence of carditis, but you may get on echo. And therefore the echo is must. Till this, I will say revision, echo was not in the criteria. So please note the very important point, and it is going to be asked commonly in your exam if the rheumatic case comes. That the cutoff value from the population, low risk and high risk. That is the very important. And with that reference, cutoff value for acute phase reactants, ESR, CRP, as different. That you should note it. I don't remember at present, but you should note it. Second point, very important, regarding the polyarthralgia and monoarthralgia. For even the high risk group, monoarthralgia is also considered the major. That's a group. Third point even regarding the cutoff value for the fever. That is also the one point, and subclinical carditis, therefore the echo. So I think, and maybe some other probably, but these are the major changes in the rheumatic modified Jones criteria. So all of us should know. And already we have crossed the allotted time to us. We'll have to end over here. But I'm sure that what we learned today, that rheumatic fever or rheumatic condition as a whole has gone down in our country compared to recent past, but it is not totally out. Another point that yes, rheumatic carditis and even the Sydenham's chorea, it was a very good case in today's presentation that we should keep in mind. Please don't forget for the penicillin prophylaxis in this patient. Exact indication, doses of even according to the weight, more than 30 kg, less than 30 kg. Penicillin is the drug of choice, usually injectable, very difficult to get it. As is the Penidural, long-acting penicillin, which is available. 3 weeks in the books, Western books, they are given the 4 weeks also, but our cardiologist group, I will say, because we are in the high risk group falling, they recommend the 3 weeks duration. If it is not available, oral penicillin, that phenaxin methyl penicillin, penicillin V, what we say, can be used. If penicillin hypersensitive problem is there, we can go for erythromycin. As a whole, I will say macrolide group. Commonly, we can go for the erythromycin. And even the sulfa group is also there. So I think these are the prophylaxis. Then again, understand primary prophylaxis, secondary prophylaxis, and even tertiary. Duration is also very important. That with this, suppose rheumatic fever, established cardiac condition, how much we should go. Ideally, they say the lifetime. But some more possibility of developing these carditis, they have defined some short duration. The longer duration, either the age of 18 or 25, or 5 or 10 years from establishment of the disease. But really established cardiac disease, I think we should go for the lifetime. So many such things are there. Another thing I will say, very long history of the rheumatic, that molecular mimicry is the main, I will say, understanding regarding the pathophysiology. And therefore the people say that rheumatic licks the joint, but bites the heart. And therefore many times the problem is due to this. You know that the involvement of basal ganglia, joint and heart, because they are having this molecular mimicry between this, I will say, antigen of these structures and even these streptococcal structures. So that's the main genesis. Many more things are there. Very interestingly, I will say Nelson recently, 22nd edition, they have described. Every student is requested to go in the details, and I'm sure that even if the exam, the case is there, you can answer it very nicely. Of course, now we'll have to end over here. Let me appreciate Dr. Nikhila. You have selected, I will say, the very good case, going down, but yes, very clearly good presentation with the patient, not good for the patient, at least for our learning. And your presentation was really confident with very clear, even good presentation, excellent. Of course, naturally, I understand that your mentor, Dr. Murki, must have taken lots of the pain. Even from his comment, we understand that besides neonatology, he is even the good basic pediatrician also. And of course, all the students, those who are really interacting with me, I request the students, please remain in the contact with me. I think some of them, those who are very, I will say, very active, quite good responding, Monica, even Nikhila, Dr. Teja, so many other students, some were silent, but I'm sure that in the future they will become more active. Of course, we'll have to express our gratitude to our office bearers, Dr. Neelam Mohan Madam as a president, and Dr. Ruchira Gupta as a secretary, for providing us this platform for our learning. And of course, the whole team, Dr. Arif, and so many other our colleagues are taking, I will say, interest to manage this show. And it's always good that senior persons like Dr. Alok Gupta, Dr. Murki, even Madam Dr. Kirti, in spite of her speciality of neurologists, she remained present. Thank you very much, all of you. Thanks a lot. Again, next Tuesday we'll be there with some new case. Over to you, Dr. Arif. I think we have overshooted some 5-10 minutes, but not that long. Thank you very much. Thank you, all of you.
Thank you, Baldev sir, for the nice discussion. Thank you, Dr.
बलदेव जी, मुझे
Srinivas
तो
sir.
यकीन नहीं होता है कि कोई इतना अच्छा कैसे हो सकता है। 2.5 घंटे में मेरे स्टूडेंट को बोल रही थी, भाई साहब कितना बड़ा एडिक्ट है ये। लोग बोलते हैं एडिक्शन होती है, मैं तो आज एडिक्ट पढ़ाने का देखी देखी हूँ।
Madam, very nice of you for
मैं
providing
पूरा
this
नहीं सुन
platform.
पाई, झूठ नहीं बोलूं। I was preparing the A to Z nutrition module. तो आज पूरी ओपीडी ब्लॉक करी मैं। एक
Madam-
पेशेंट नहीं देखी, टोटल 2 पेशेंट देखे हूँ, सिर्फ 2 पेशेंट सुबह से। ये देखो 2 पेशेंट I saw, रेस्ट ऑल देश का कल्याण करी, न्यूट्रिशन मॉड्यूल पूरा बना दी।
Madam, as a president, naturally you cannot pay the attention to the patient and other things. Your total focus will be
It was
on
very
IAP.
important for me to do.
Yes, yes.
मेरा न्यूट्रिशन मॉड्यूल जब आएगा तो जरूर अटेंड करना आप।
Certainly, we learn.
And all the students, please convey to each other that 5 zones. We are doing IAP Action Plan PG Parikshati, which is a state-of-the-art 3-day program. You all will love it. Just for nominal 500, 600 some registration. But I have to keep it for IAP associate members. Are they postgraduates who are not IAP members?
Please, I think you should be at least associate. After passing your MD examination, you can be
It is,
regular.
no, but are they IAP associate members? That's what I'm asking. Will
Well,
I be,
madam, only the 20-30% students are the associate member.
Yeah,
Rest
so
all
I
are
think-
they are not members.
So all the
they are
teachers
not-
can motivate. Teachers can motivate their
So how
students.
So we'll
to-
motivate them.
No, then that is what I'm getting confused, because then in that case I'll have to give it like for the members I'll have to keep 500, and for the non-members should I keep 3,500? कुछ तो
Yes, madam.
हाँ?
नहीं,
तीन
madam, this is a
दिन
good
का-
idea. This will push them to buy a membership also.
हाँ, तो 3.5 ठीक है, 3.5 या 4 करो, क्या करूं? 3 दिन का है फुल।
Madam, 4,000 भी better because food ने वो सब भी थोड़ा मतलब
नहीं, वो तो
उसके
मैंने
हिसाब से भी-
बजट डाला है, तो चलो मैं, ताकि उनको इंसेंटिव रहना टू बिकम अ मेंबर, और मेंबर्स को
Yes, ma'am.
500 रुपए ऐसे नॉमिनल, वो भी जस्ट सो दैट एंट्री रहना, दैट्स ऑल।
Yes, madam.
ठीक, चल, ओके,
Thank you. Thank you.
बाय। सबको
Thank-
बोलते रहना। ओके आरिफ जी, बाय।
Yes.
Thank you, madam.
Thank you, madam. And again, next Tuesday at 6 o'clock, we'll be there with some new guests.
Thank
Good
you,
night.
sir.
Yeah.
Who's 1 minute? Who's this John? 1 minute. Who's John? I don't
Yeah.
see him. Who's John? John, where are you?
Yeah, his comment is there. John, I think
Yeah, where are you?
you should
Please,
come
I
out.
don't see
Yeah.
you, John. Who's John?
He has put on the chat box.
John, can
He
you
must be
unmute
there,
and say?
Yeah.
So I will ask me what you want. Just ask me and you'll get it.
Hello, ma'am.
Yeah.
Good evening.
Which book do you want?
Ma'am, actually, I wanted to say if we could get at least soft copies of these newly released IIP textbooks, like
Which one?
the vaccination book, which was recently released,
Purple
the updated
book.
one,
Purple
Okay,
2025.
so all are getting free books. Whoever is joining the course, are you familiar?
No, ma'am, I'm already passed
Okay,
out.
I will.
Yes, ma'am.
I will put that book on the website. IAP.
Okay, ma'am.
Yes.
Okay, ma'am. Thank you.
Right. बेटा ये लिख लो आप, तो मेरे को कल याद दिलाना. John, message me by Thursday or tomorrow. Wednesday. No, you message me Wednesday or Thursday, and I'll see to get it loaded. Okay.
Sure, ma'am.
What
Sure,
else you
ma'am.
want?
Thank you.
What else?
And ma'am, the IIT textbook on endocrinology, I don't know if the recent edition is out. That one by Vaman Khadilkar sir.
Go and buy it.
That one.
Yes,
Yes, ma'am. Yes.
he won't give me his kadus. I am big heart. Okay.
Thank you, ma'am. Thank you,
Hello
ma'am.
जी, प्रणाम आपको.
Again, thank you all of you and good night.
Good night.
So we'll be there on next Tuesday. Dr. Charul is also there. Arif from your department, Madam is also there.
Good evening, sir.
Yes, good evening, Charul.
Yes, sir.